You are listening to another Discovering New Horizons for America podcast, featuring author and certified nutritionist James Polikoff, also known to many as Dr. Jim. Our guest for this New Horizons episode is Dr. Kevin Jackson, a specialist in heart disease. As always, each episode is a search for the truth and how it applies to your daily lives and well-being. Now, here to take you on this exciting New Horizons journey is our host, Dr. Jim Polikoff.
Good day. This is Dr. Jim Polikoff. I first want to thank the thousands of listeners who join me every week because you've helped make this podcast a real success. Again, thank you so much. Keep listening. This episode is dealing with a very particular disease that I want to discuss because over 3 million Americans suffer from irregular heartbeats, often referred to as atrial fibrillation. Now, this number is expected to double in the next 8 years. So as a result, this special episode of Discovering New Horizons in America will spotlight this often terrifying heart disease, which can lead to debilitating strokes. My guest is Dr. Kevin Jackson of Duke Health in Raleigh, North Carolina. Dr. Jackson is at the forefront of medical advances to treat this disease. In fact, I must admit, I once suffered from atrial fibrillation, and it was Dr. Jackson who performed a catheter ablation procedure that cured me of AFib. I haven't had it for years, thank goodness. So, welcome to Discovering New Horizons for America, Dr. Jackson, and thanks again for curing me of my problem.
No, my pleasure. I'm glad to hear you're doing well.
I'm doing very well, and a number of years well. So let's begin with an overview of atrial fibrillation and the dangers it presents. Can you explain that?
Sure. As an electrophysiologist, I really deal with all electrical problems of the heart, but atrial fibrillation far and away is the most common thing that I see. And it is the most common arrhythmia that we see in the United States and probably worldwide. Right now in the United States, there's roughly 3 million people walking around with atrial fibrillation. And we're seeing more and more of it. I think, atrial fibrillation is a electrical problem that occurs as people age. So as our population ages, we're going to be seeing more AFib. And, the estimate is within the next 20 or 30 years, that number may double. We'll see 5 or 6 million people in the US with AFib. There's important implications of atrial fibrillation. It's a common rhythm. It generally has been sort of labeled a benign arrhythmia, but I think that's not really true. If you look at population studies of patients that have atrial fibrillation, there is a definite increase in mortality in people who have AFib. So it's hard to tease a lot of this out because it runs with other diseases like hypertension and other heart disease, but it seems that AFib alone is a marker for worse outcomes, including worse mortality for people. So, we certainly treat this seriously and aggressively for those reasons. I think we'll get into it a little bit, but the big problems with atrial fibrillation are stroke and heart failure. Those are sort of the two things that we really focus on. And of course, a lot of folks have symptoms from the irregularity of the heart rhythm. So, when I see a patient in clinic and they're brand new diagnosis of atrial fibrillation, we are talking about some serious things, including their risk of stroke and their risk of heart failure.
So what are some of the early signs of AFib, and what kind of medication generally is used to control it?
It's really across the board. A lot of folks, of course, AFib is an irregular heart rhythm. It's a fast, irregular heart rhythm. And some folks will feel that. They'll feel a sudden change where their heart rate goes up, their heart rate gets irregular. Some people describe it as a fish flopping around their chest, or just some very uncomfortable feeling with the heart racing and being irregular. But actually, there's a fair number of patients who don't feel that at all. They have no awareness of their heart racing or the irregularity of it. And what they feel is fatigue or shortness of breath with their activities. inability to go up the stairs without having to stop halfway, or intolerance of climbing their neighborhood hill, or something that they normally could do without a problem. Suddenly they've realized, hey, I'm really tired or running out of my breath doing these kind of normal activities, and they may actually have no sensation that their heart is racing. So we certainly think of the fast irregular heart rate as the signature of atrial fibrillation, but it actually can present with a lot of symptoms, including no symptoms. There are people who come in, have absolutely no awareness of it and no symptoms from it, who it really is diagnosed either incidentally because their physician picked up, an irregularity to their heart rate on an exam, or they had an EKG done for some other reason where it's picked up. And I certainly see a fair number of those patients as well.
So I would think that this is even more important that people get regular checkups from their primary care doctor who might pick something up, as opposed to many men who just put off seeing doctors as long as they can.
Yeah, regular checkups for sure, for this and for other reasons. Certainly as you get older, part of that regular checkup is going to be an EKG, where they're going to look for these sorts of rhythm problems. And critically, I think, again, folks think that, oh, if my heart's normal, I don't feel the palpitations, I couldn't have atrial fibrillation. And that's far from the truth. We definitely see folks that present with more subtle symptoms: fatigue, tiredness, shortness of breath, these kind of symptoms, or even lightheadedness, where there's no good explanation for it. Those are the symptoms where folks really should, be evaluated by their doctor, because it could be a sign of atrial fibrillation for sure.
So if somebody starts in as diagnosed early with AFib, what types of medications are generally, prescribed to control it?
I mentioned the two kind of big risks of atrial fibrillation: stroke and heart failure. So the medications are really focused on preventing those. And the first would be a blood thinner. And really almost across the board, somebody who has atrial fibrillation, we're at least considering starting that patient on a blood thinner. And there's different types. There are, aspirin certainly is a type of blood thinner that we have historically used for AFib in really low risk patients. I will say we don't really use that much anymore. Mainly we talk about Coumadin or warfarin, or the newer types of blood thinners. So that's really the first medication we're looking at. And that, the good news with that is that they really dramatically reduce the risk of stroke from atrial fibrillation. So they're excellent medications, generally really well tolerated. Of course, blood thinners do have some bleeding risk, and we have to consider that with the patients. But that's the first order of business often with atrial fibrillation. It's just really addressing and potentially protecting the person from that risk of stroke.
Well, you mentioned, rapid and irregular heartbeats in many people. That's what is, more or less that's what they feel, and not always, but in many cases. But I think there's a concern, of course. I remember a concern trying to estimate the difference between AFib and ventricular tachycardia. I know the latter needs urgent medical care. How do you tell the difference with an AFib patient? When should they really be concerned if the rate increases?
If you just look at the commonality of these rhythms, AFib far and away is the much more common rhythm than ventricular tachycardia. They usually happen in different patient populations as well. We certainly see ventricular tachycardia as an electrophysiologist, not uncommonly, but it's more often in a patient who has had a prior heart attack, myocardial infarction, a patient who has heart failure, known severe heart disease. Certainly people with normal functioning hearts, healthy folks, can develop ventricular tachycardia as well, but that's fairly unusual. The difference is really a few things. One is ventricular tachycardia often is a very sudden, fast, but regular heart rhythm. It doesn't skip around. So that fish flopping in your chest where the heart rate goes up and down, that's sort of really classic for atrial fibrillation, whereas ventricular tachycardia is often fast but quite regular. It often, again, more so because it's in patients who have underlying heart disease, it's much less tolerated. So patients may have severe dizziness or pass out from it. And as you said, it can be in certain circumstances life-threatening. in patients at risk who have had heart attacks, who have poor heart function, who develop ventricular tachycardia, I mean, we're considering things like defibrillator and certain very substantial medications to try to prevent these episodes. So it's really a different situation. It's a fast rhythm, and so it may feel the same for any given patient. And certainly there's patients who have both, who have atrial fibrillation and ventricular tachycardia. But it's generally in the healthy patient who has a new onset of a fast rhythm, especially if it feels irregular. Very unlikely that's going to be ventricular tachycardia. Not typically. It's going to be much more often it would be atrial fibrillation.
Now, as a nutritionist, I think I know the answer to this, but can changing your diet affect or minimize AFib if you go to a different type of a diet? And if so, what do you recommend, or is it really just a waste of time to consider that as a remedy?
I would never tell you that nutrition is a waste of time, not to a nutritionist, nor do I think that. But, I think what we've learned with nutrition and diet and atrial fibrillation is that it is important to the degree that weight loss is important. So, I'm not familiar with any compelling data that says one particular diet or type of food over another is going to eliminate atrial fibrillation. But weight loss is certainly critical in both managing atrial fibrillation and potentially as a sole treatment. So obesity and AFib and obesity and heart disease go together. And so weight loss as a treatment for AFib is always a goal. So I guess in that sense, nutrition is critical. The type of diet, I think, is less well known. I think people have looked at different types of, or different nutrients, different types of diet to say, are these pro-inflammatory or anti-inflammatory? Can that have an effect on heart disease or on atrial fibrillation? I think certainly fish oil is something that we've looked at for a long time in cardiology to say, does this have some anti-inflammatory properties which may benefit patients for heart disease, but also specifically for AFib? I think, in my reading of the data, it's been fairly disappointing, or I guess another way to say it, the effect has been fairly mild. I think there's a lot of benefit to fish and fish oil.
The omega-3s.
Omega-3s, certainly. But, looking at refined omega-3s in the form of Lovesa, for example, the trials were really negative. So at least that form of omega-3 in pill form did not have a strong benefit for preventing atrial fibrillation. I think, as with all things, I think the more natural forms, if you can get your omega-3s through fish or through vegetables, that's probably preferable because you're getting the other nutrients along with it. It hasn't been a strong effect with atrial fibrillation, but I think there is some effect there. The other thing that people look at with AFib is caffeine intake. And I would say really to the excess, if you are, a triple latte kind of person daily or 4 or 5 cups of coffee per day, there does seem to be an increased risk of AFib. But if you are a moderate caffeine drinker, meaning 1 or 2 cups of coffee or caffeinated tea daily, really there doesn't seem to be a strong effect. So the good news for caffeine drinkers out there is they really don't need to be abstinent. I do not recommend my patients give up caffeine. I think that's a tall order for anyone. I'm a caffeine drinker, a coffee lover, so I certainly wouldn't want to do that myself, nor do I think the data really supports it, unless you're really at the excessive level.
Well, and that's good news because there are so many benefits, as we know, from caffeine, derived from caffeine. Now, stroke is perhaps the biggest danger that a person with AFib would face, I'm imagining. So if you find someone with AFib, do you immediately address the stroke aspect of it and prescribe certain medications?
Yes, I think that's really the first thing that we think about. It certainly is the most devastating outcome of atrial fibrillation. It is the most common cause of stroke, atrial fibrillation in the United States, whether it's a patient, it's known atrial fibrillation the patient has or undiagnosed atrial fibrillation. So this is not an uncommon thing. And so it's the first thing that we think about. Now, just having atrial fibrillation, although it increases the risk of stroke, that alone is not the sole decision or decider on somebody being anticoagulated. There's other risks that go into it. So, a young patient who has no other risk factors, no high blood pressure, no heart failure, no diabetes, and just has atrial fibrillation, they may not have such a strong benefit from being on anticoagulation, at least early on, and we may make a decision not to anticoagulate that patient. That's a fairly small subset of patients with AFib. For most patients, certainly over the age of 65, or patients who have high blood pressure, females actually a slightly higher risk of stroke than males. Diabetes, yeah. It's one of the few areas in cardiology where women do somewhat worse than males, but females, high blood pressure, diabetes, as you get older, over 65, certainly over 75, hypertension. There's a few of these risk factors, and certainly any prior stroke or blood clot in that patient. Those are risk markers that really say this person should be anticoagulated, and we certainly would recommend putting them on a blood thinner at that point.
Well, you mentioned the formation of blood clots obviously can be life-threatening. I understand you're currently employing 2 new devices for patient protection in respect to blood clots.
Right. Yeah. So in the last several years, I'd say over the last 10 years, we have studied devices that will actually block the blood clots from getting out of the heart. So when somebody has atrial fibrillation, of course, the atrium, the upper chambers are the problem. They are fibrillating or quivering. And because the blood does not pump normally, blood clots can form. But the area where blood clots form is not the entire region of the atrium. It's actually a small area, a small sac that's called the appendage. And it's sort of the size of your index finger, maybe 2 of your fingers. It's not a large area of the heart. In this pouch or this sac, blood clots can form. And if they get out, that's what potentially could cause a stroke. And so we use blood thinner, which of course thins the whole blood, but it's really focused on preventing blood clots in this very localized small area of the atrium. So one of the devices that we use, which is called a Watchman device, has been fairly well studied. It is essentially a plug or a cork that we place with a small catheter through the leg. And through that, we're able to, through that catheter, we can deliver this device into the appendage. And essentially it opens up and plugs off that appendage so that a blood clot forms that has no passage out of the heart. We use blood thinner for a few weeks after placing that device just to allow the device to heal in. But once that's done and the device has sort of sealed off that area, we feel somebody can safely come off blood thinner, and it should protect them against a risk of stroke without having to remain on blood thinner. There's another device that's more surgical that's placed from the outside that some patients may get at the time of a heart surgery. And that's probably the second device that you're mentioning. But the one that we really place is this Watchman device. And we're starting to do that more and more. We're now on the second generation of that device. I think it's gotten better. It seals off that area a little bit better. And we are starting to do some research now to look at folks who really prefer to have this device rather than remain on long-term blood thinner. Whether that is a good alternative and protects them as well as blood thinner, that remains to be seen, but that research is ongoing right now.
Now, let's discuss the procedure that I had that was very helpful to me. And obviously it must have been undergoing some improvements since then, because it's been about, almost 5 years since my catheter ablation procedure. Perhaps you can discuss that.
Sure. So, ablation for any electrical problem has been around since the 70s and 80s. Actually was pioneered here at Duke by some of the surgeons and early cardiologists here at Duke. So there's a long history at my institution of this procedure. For atrial fibrillation, we really have been doing ablations since the late 90s. This initially, atrial fibrillation was sort of felt to be a very chaotic rhythm that was not amenable to being fixed with catheter ablation. But some very smart researchers and clinicians out of Bordeaux, France, figured out that AFib comes from really four of the veins in the heart called the pulmonary veins. These are large blood vessels that drain the blood from the lungs into the atrium, into the left atrium. And within those blood vessels, there are muscle fibers and nerves that get irritable and trigger atrial fibrillation. And once that discovery was made, we realized that we could do a procedure to potentially block that AFib from getting into the heart, from triggering and causing atrial fibrillation. And so that's done now with a catheter ablation procedure where we place long catheters or wires through the blood vessels of the leg into the heart. And in that left upper chamber, that left atrium, we ablate, usually by heating, but we can do this actually now with freezing. That's called cryoablation, but either heating or freezing the tissue around those veins. We don't want to affect the blood flow. Of course, we want to allow that good oxygenated blood to get into the heart from the lungs, but we are essentially blocking that AFib from getting into the heart once we do this ablation. I'd say your ablation 5 years ago was a pretty state-of-the-art ablation. There are some improvements we've had over the years. I think there's going to be further improvements even within the next couple of years. Right now, when we do an ablation on my patients, I will typically tell them this, and looking at the data, this has about a 70 to 80% chance of working. As a one-time procedure to fix AFib, allow you to come off of some of the medications we use, 70 to 80%, with a low chance of a complication. The risk in an experienced center is about 2% of a complication with this procedure. It's typically about a 2-hour procedure. It's done under anesthesia, so the patient's asleep, but it's all with catheters through the veins in the leg. It's obviously not an open chest procedure.
And you pretty much can stay overnight at the hospital and go home, correct?
One night overnight, although now this is something that's changed since your procedure. We are doing same-day discharge. So I would say over half of our patients now, it's become, I wouldn't say routine, but certainly a efficient enough procedure that after a few hours of observations, patients can actually go home and rest comfortably in their own bed at home on that same night. So that's about half the patients actually are going home the same day. So that's been a bit of a change since your procedure.
Well, I would think that would be very exciting, the same day. As far as let's talk about the pacemaker for a second. I mean, for those patients who you've tried what you can and it doesn't seem to work, would the next step be inserting the pacemaker to control the contractions?
Yeah, I think this is a very common question about AFib is, why not put a pacemaker in for this? And, I would say on occasion we do that. It's certainly not the most common treatment for AFib. And the reason is pacemakers really are designed to prevent slow heart rates. Well, that is sort of the opposite problem with atrial fibrillation. So why would we ever put a pacemaker in for AFib? Well, the reason is there are some patients who have both fast and slow heart rates. So they require medication or ablation for AFib plus a pacemaker to manage the slow heart rates. But I would say more in patients who have AFib, who have either failed medications, have failed an ablation or even a couple ablations, and they continue to have atrial fibrillation. Sometimes what the option then is to more or less eliminate the electrical activity in the heart. There is a region of the heart called the node, which transmits all of the electrical activity from the atrium, from the upper chambers to the pumping chambers, the ventricle. And if we basically ablate or cut off that node, then none of that electrical activity from the AFib will generate a heart rate. So the heart won't race, but at that point, you're committed to placing a pacemaker in the patient. So that's often, it's certainly not the first treatment for AFib. And it's often after a failed medication or a failed ablation, but it certainly is a treatment that we offer in a patient who's highly symptomatic, continues to have fast heart rates, uncontrollable. We will think about doing this node ablation where we're really cutting off the electrical current and then placing a pacemaker. And patients, the good news about that is patients can feel quite good with that. It often eliminates a lot of the need for medications, not blood thinner, of course, because they still need that for the stroke risk, but some of the other medicines that we have to use to control heart rates, we can get rid of those once we place a pacemaker.
Now, I understand, and I'm not quite sure what this means that you're investigating a new, would it be a leadless pacemaker as well as new technology?
Yeah, so I have, and Duke's been involved in kind of the next generation of pacemakers. And this is, pertinent for patients with atrial fibrillation, but really any patient who we are thinking about placing a pacemaker. More often that's patients who present with very, very slow heart rhythms or pauses or have passed out because of some interruptions of their heart rhythm. And leadless pacemakers are devices that are placed directly into the muscle of the heart. There's no incision. So with a traditional pacemaker, we're making a couple inch incision over the chest muscle. We're placing the device under the skin over the chest muscle with some wires that travel through some blood vessels into the heart. So certainly a fairly invasive procedure with a surgical scar, not a complicated procedure, but something where the patient has, clearly a visible scar and a device in their chest that they're very aware of. A leadless pacemaker is really a sea change from that. And this is placed with a catheter, very similar to your ablation procedure, where through the blood vessels in the leg, I can place a long tube and deposit a very small device. It's essentially the size of a Christmas tree light. And that has some tines or hooks on it, which hook onto the muscle from the inside and allow us to do pacing from the inside of the heart chamber. And once we've placed that, we remove the catheter. The device, of course, is left on the inside, but essentially the patient has no scar, no device that they really are aware of. And it does all the normal pacing function that a pacemaker can do. So patients really love this device. We've been placing these now for well over 5 years. And in the appropriate patient, this is really a remarkable device. The batteries can last 12 or 15 years. The patients really don't even remember that they have a pacemaker because they don't have that visible scar, they don't have that bump in their chest, and the devices work wonderfully. So I think this is where we're moving in electrophysiology is towards smaller devices, leadless devices that are placed, with catheters and less invasively. And I think that's going to be a big benefit to our patients.
Well, it's amazing how Duke continues to be on the forefront of advances in almost every area of medical technology. That's almost as big a news as Coach K retiring. How do you feel about that?
We're all depressed about that for sure.
Well, Dr. Jackson, if somebody wants to get a hold of you, I would imagine the best way is to call Duke Raleigh Hospital in Raleigh, North Carolina. Am I correct?
I work both at Maine Duke, which is in Durham, North Carolina, and Duke Raleigh. And yeah, I think, through the Duke Health website, through our cardiology website, you can get in touch with me. And, I'm available for consultation and seeing patients, and of course, doing procedures for those that need it. And I'm certainly happy to see any patient who has atrial fibrillation or any electrical problem. But yeah, I think through the Maine Duke University Health System website, whether it's through Durham or Raleigh, is the easiest way to get in touch with me.
Well, unfortunately, additionally, our podcast website, I'm going to ask our listeners if you're interested in getting a hold of Dr. Jackson's scheduling a consultation. Go to our website, www.bodymindsoulpodcast.net. And of course, I'll be repeating that again towards the end of this podcast. But Dr. Jackson, this has been extremely informative. And I know that there are so many people that when they have atrial fibrillation, there's a great deal of mental suffering. As I mentioned at the beginning, I was even hesitant to get on an airplane because I wasn't sure what would happen if I didn't have any medical help, should my AFib get out of control. And there are people who are frightened and living in fear. So it's good to know that things have come so far and that you're available. And again, I really appreciate you being on our show.
My pleasure. I'm glad you're doing well. It was nice talking with you.
It was good talking to you too. Thank you.
You're welcome. Take care.
You can discover more information about treatments and advances in atrial fibrillation by coming to our website, jamespolikoff.com. That's James, P-O-L-A-K-O-F.com, jamespolikoff.com. You'll also discover a wide variety of valuable resources on our website and other terrific New Horizon podcast episodes. Plus, if there are any topics you would like us to cover, shoot us a message. Again, that's jamespolikoff.com. Now back to Dr. Jim.
Thanks again to Dr. Kevin Jackson for his valuable insight into atrial fibrillation and the life-saving advances that he and Duke Health have made in treating AFib, as well as improving the quality of life for its victims. So now I'd like to share a few healthy eating tips with you. By any chance, do you eat 4 to 5 cups of fruits and vegetables every day? If not, you should consider doing so. And do you get enough calcium? Do you eat whole grain, high fiber foods? If so, you're on the right track. But also, you need to reduce your consumption of red meat. If you eat a lot of meat, try to cut down on it. As far as chicken is concerned, or turkey, remove the skin before cooking chicken or turkey, and eating fish once a week is a great plan. Cut down on buttering bread and sour cream on baked potatoes. Instead, use low-fat or non-fat versions of these foods. This is Dr. Jim Polikoff. Be sure to keep joining us for a New Horizons podcast episode each week. And please visit jamespolikoff.com for healthy tips, informative blogs, and many great podcast episodes. Thanks for listening.